All right, guys, it's 4:05. We have a good show of people already, so I think we're ready to get started on April's NASCI Curious Cases webinar. My name is Jacob Kirsch. Been a NASCI member for several years now, and very happy to be here hosting this for you guys today. I did prepare a couple of cases, but as usual, this is an open forum. Everybody's welcome and actually invited, and I certainly hope that as you keep coming back, you bring your own cases to show to the group and ask questions, get opinions, or just do a bit of a show and tell of anything that you think is worth sharing with the cardiovascular imaging community. So having said that, I want to welcome you all. I see a few familiar names on the list and some that I haven't seen before, so everyone is welcome. Anybody who would like to start showing cases, and I can definitely make you presenter. Don't be shy, guys. All right, well, you guys.
Why don't you go first, Jacobo?
Exactly.
I have a couple.
While you guys get your stuff together and ready, I can start presenting. And thanks for joining, Carol. Let's see. I'm going to try now to switch the screen that I'm showing. There you go. Everybody should be able to see my DICOM viewer screen. So I'm going to start this by asking a question, and you can either respond verbally or put it on in the chat. I have a Mac. I use Osirix, but Osirix keeps putting more and more obstacles to show cases, and they are trying to push into buying their FDA-approved expensive version. So people out there using Apple computers, what DICOM viewers are you using?
I have Osirix.
You have the same problem than me?
I have some version, not the free one, but it's not the real expensive one.
Okay. Yeah, I think I'm gonna have to give in and buy one of those versions. It's having issues even opening large exams like CTAs and stuff. So I'm gonna be showing most of my cases here on the browser view, which it's good enough, to be honest with you. All right, so let's see. I'm gonna start with this case, and I know that we have a couple of trainees here. So if somebody wants to make some comments about what we're seeing here, and I'll give you a little bit of the story on this patient as you guys unmute yourselves. This is a 66-year-old female with, 66-year-old male, showed up with a history of a resected fibroelastoma back in 1967. And that's a bit of a red herring there. Has actually probably no relevance to what's going on, but he did have a history of cardiac surgery back in 67. Presented with ventricular tachycardia and progressive CHF symptoms. And then this is what the chest x-ray looks like. Does it look normal? Yes, no? All right, it looks abnormal, right? It has a weird contour to the left heart, elevated and prominent for sure. It's a little bit obscured by that AICD, so we see that the patient has a biventricular device in place. The lateral, I don't think it shows much more, although you do see here some epicardial leads here, an epicardial patch, I should say, by the way that they are organized. So the patient did have imaging before coming to our institution, had of course, chest x-ray, but also had an echo that showed enlargement of the myocardium. They thought there may be a mass, so they went in and did a biopsy, and they left those leads in place after the biopsy. So from there, he went to have a CT. Let's see if he probably won't open these ones here. Yeah, he won't open them here, so we're going to look at them here. So you can see as we go caudal towards the head, there's definitely something going on here in the anterior wall of the left ventricle. There's this mass-like process with some coarse calcifications. You actually see the vessels kind of just almost draping over the mass there, and with a slight intra mass or intramyocardial, of course, almost like if they were bridging into the mass. And this is the epicardial patch and leads that they left after the biopsy of this mass. And again, some punctate calcifications in it. And here you see the coronal, and it kind of helps us understand what that upturning and prominence of the left ventricle was on the chest x-ray. So again, this mass with some of those vessels going straight through it. So when you see a mass like this, which appears to be within the myocardium and very large, may have a few punctate calcifications within it, what do you guys think of? Any suggestions? So this
What was the time of onset?
go ahead, I'm sorry.
Sorry, I was going to just ask. I was just going to ask what the timing was with regards to, I guess, how long do we know that this mass has been here? Or is this the first study that was discovered?
No, this is the first study that I have from the last this is the last exam done at the prior institution before he came to our institution for definitive treatment. I don't know how long this been going on, the symptoms or any evidence of a cardiac mass, either by imaging or symptomatic.
Did the patient have any systemic symptoms like fever, malaise, anything like that?
Nope. So it was more like a CHF type symptoms and ventricular tachycardia.
Okay.
However, I think by imaging characteristics, we should be able to have a very good guess of what this turned out to be. So you have an intramural mass, so within the myocardium, somewhat homogeneous, with some calcifications within it. So I'm going to show you what happened to this mass. In 1 second, let me just open up the path specimen, and that should definitely help you guys see it. And Dr. Lidmanovich is joining us. What a treat.
Hi, how are you?
Good. So she's going to tell you exactly what this is. And I guess she's going to tell you because I put the label on it. So this is a explanted heart. So the patient actually ended up having a transplant that was required because of that large infiltrative mass. So patient went for cardiac transplant. So this is what it looks like. It's upside down, I guess. When you look at this image, I'm sorry, it's that I'm showing the slides like this and not in presenter mode. So you have the mass. This is the right ventricle here. So you know, for anatomical purposes, you would like this flip 180, rotated 180. But you can see this very fibrous tissue going into the heart. So again, this is the second most common congenital tumor. It's basically a hamartoma, which is fibroblast and collagen within it. It says here it's most common in infants, but can be seen in young adults. So it has a bimodal presentation, both infants and young females usually. So this is one of the rarer cases of male. And this patient is because of those tachycardias and additional ectopic rhythms are at risk for sudden cardiac death. So that's why the patient had the ACD, but also why the patient eventually ended up with a heart transplant because of the CHF caused by this huge mass at the heart and by the tachycardias. So let me just see if I can change this now and show you. I want to show this to you. Just want to share my screen. There you go. So I can show you the actual movies. So I found this other case that I have. So I made a companion case, and you can see what it would look at on MR. So again, this is a steady state, the workhorse of cardiac imaging. You can see a 2-chamber view, and again, a very large intramyocardial mass in the anterior wall of the left ventricle. It's a middle-aged female. This is a relatively old case that I had. But it's a very nice correlation. On the 4th chamber, you see here that it also extends towards the lateral wall of the left ventricle. Not too different from the CT case that we saw. And this is what it looks like. So on a black blood sequence, again, somewhat homogeneous to myocardium, and that's pretty characteristic of fibromas. It's either homogeneous or slightly darker than myocardium on all sequences because of that high fibrogen component to it. And this the turbospin echo T2, so things myocardium tends to look dark as well, like the blood, so it darkens with it. And here, this is probably the most classic finding on your late gadolinium enhancement because of all of that collagen, all that abundant extracellular space within the mass. They're going to just really take and preserve some of that gadolinium in it for those late enhancements. So they're going to be pretty bright when you do this images. And here it is in short axis. So again, just a companion case that set by a different patient, but very, very similar looking mass. And these are out of order, but there's the perfusion. It perfuses pretty much in close proximity with the perfusion from the myocardium. Okay, that was that. So now I want to show you. We're going to go back to Osiris for a second. Which one is it? I want to say it's this one. So this is a patient which showed up also with an abnormal echo and some shortness of breath. I think it was the initial symptoms on the dyspnea, and this is what it looks like. So this is a 2-chamber view, steady state, and you can see that mass-like appearance of the anterior wall. 3-chamber, you can see here how mass-like it is, pretty round, and definitely obstructing the LV outflow tract. Any comments? What do you guys think so far? I want to show you 4-chamber. This is more medial towards the septum as opposed to the other case that I showed, which was lateral. What are you guys thinking? As I continue, just go look at that. These are note takers. I want to show you the late enhancement, and you tell me what you think. So let me see where my PSI are. Here they are, short axis. So very different to what we saw in the prior case. This is not a fibroma. This is just very focal hypertrophic cardiomyopathy, centered about the anteroseptal segment of the left ventricle, about the base and mid ventricle, I guess, levels. But you can see it's very faint and patchy hypertrophic cardiomyopathy. So yes, Jacob, you got that on the comments there. You put HOCM, and yes, it's basically that's what this patient has. But again, without the contrast, it can be hard to tell them apart sometimes, depending on the location of the mass. So it was, again, just another companion case. Let's see. This is what it looks like on the stack of 4 chambers. You can see very faint, patchy enhancement. So this is a nice, dramatic case of that. Let's see. I have a couple more cases. How are we doing? You guys want to show a case, or should we continue? All right,
I can show a case,
all right. So,
or I can wait until you're done with your cases, Jacob, or maybe somebody else would like to show a case.
I know Carol has a case. You have a case. Anybody else? I just want to make sure that I want to be respectful for everybody's time. If you prepared cases, I would like to let you show them. All right. So what I'm going to do is I'm going to go quickly through this, and then I have 2 more cases, I think, and then we'll switch gears to you guys. This is an interesting case. This is a female patient, 43-year-old woman with Lynch syndrome. Lynch syndrome, LYNCH, is a syndrome that predisposes you to different types of cancers. So she actually does have an advanced stage sarcoma with some what they think is a soft tissue primary along the buttocks and so the gluteal region. Also already with brain metastases. And she presented to the ER with a syncope. The chest x-ray looked funny. Of course, they did a CT because everybody does CTs nowadays. And this is what the CT of the chest looked like. So I'm just going to start from the top here. So you can see right away, there's very nodular, mass-like structures where you would expect the aortic recess or the superior recess of the pericardium. They're high in density. You can see this nodular thickening of the ascending aorta. So you can look at the descending aorta. The wall is almost imperceptible like it usually is. Here it's kind of thick and nodular. And then as you go down, you see this luminal filling defect in the aorta, which communicates with that nodular wall as well in this patient. And we continue to move down and we see this high attenuation, very nodular pericardium / pericardial effusion all the way down. And then very heterogeneous. You can see here, if we window it a little bit more narrower, you can see some pooling here in the bottom of the pericardial space, this high attenuation material. So patients, after an echo, was shown to be on tamponade. So was taken to the OR for a pericardial window, which just started showing a lot of blood, or draining, I should say, a lot of blood. I was a bit concerned when they did the procedure because of this. When you look at the very base of the heart here, lateral left ventricle, you see this little pulling of contrast in the myocardial wall. It looks like a cleft, and I was concerned that was actively extravasating into the pericardium, and by doing that window, the patient was just going to continue to extravasate because you cannot contain that bleeding anymore within the pericardium. But that did not turn out to be the case. I did talk to the surgeons beforehand to let them know about that little finding and my concerns, but that's it seems like it was just a little cleft with the myocardium that was going nowhere. So patient still with us, but with metastatic gnarly cancer. And I'm concerned that there's pericardial involvement, of course, and that there's also this big piece of cancer protruding into the aorta that at any given point may either dislodge a little piece of it or some thrombus associated with it and give the patient a bad stroke as well, just to make things worse. Any questions about this case? Has anybody seen something like this with masses protruding into the aorta like that?
Was it ever biopsied if any of the cardiac or pericardial involvement?
No, I'm waiting for, I asked them, I wanted to see if they would do anything, but no, I don't have any PAD results. I would assume that from the pericardial window, let me go back and check as we speak, but I would have assumed from the pericardial window there would be some reports of a piece of pericardium or something like that. Let's see, surgical pathology. Chronic inflammation and hyperplasia of mesothelial cells. So I guess we can see that the patient now has a mesothelioma on top of whatever, but the presence of mesothelial cells doesn't mean that it's mesothelioma. It's actually relatively common to see some mesothelial cells on pericardial effusions. So nope, nothing else here.
Is there an aneurysm of the origin of the right coronary?
Mm-hmm.
Yeah, actually,
Yeah.
Yep, good call. Yes, there's something there. We did mention that. I forgot to mention it this time. It's a case from about a month ago. So it's either that or just adjacent to it. But it definitely looks to be contiguous with the origin, if you think that the origin is right there. Yeah, good pick up on that one, Carol. And I have no idea how that would be related to everything else that's going on. That may just be an incidental at this point on this poor lady. So this is that case with this advanced sarcoma, which we assume this all related to metastatic disease from that. And last but not least, this is an interesting case, and I'm glad that Dan is here because Dan wrote the seminal paper on this pathology. I'm going to start with the monitoring. So this is for the bolus monitoring to trigger the acquisition, the angiographic acquisition. So just please pay your attention at the proximal right ventricular outflow tract, or right above, I guess, the proximal pulmonary artery, right above the pulmonary vein. And you're going to see as the contrast goes in, you see that there's that area there, that's kind of like a blush that never enhances. You buy that? You guys believe what I'm saying? Everything should enhance homogeneously. So for some reason, there was not a lot of enhancement there. And then when you look at the actual images, let me see which ones to show. Let's try these ones. I'm going to go back to that area. You can see that it's the opposite effect. There's now contrast blushing into that area, whereas the pulmonary artery should have already all the contrast moved past it into the arterial side of the heart. So
Blushes or enhancing?
why?
Because if there is a soft tissue there, it will be enhancing.
Exactly. Well, if there was soft tissue, but there's that's a very good thought. Let's see if this is better. They're all kind of motiony, so it's not a great CTA.
Oh, okay.
But what you see here is all these bronchial and different collaterals arising here. Actually, several of them coming from the coronaries. There's one coming from the LAD going up into the pulmonary artery. There's one also from the circ going up into that area. So these are all blushing of contrast coming from those fistulations, from those coronary fistulations into the MPA. So it's a little bit of a steel phenomenon, I guess. So what we're seeing on the monitoring images here was the non-opacified blood blushing into the opacified vessel, and then the opposite effect on the angiographic phase, where you see the arterial blood now that's enhanced blushing into the non-enhanced blood. So this is just coronary fistulas to the proximal main pulmonary artery. There's just a lot of them, and you can see them here in the back as well. There's some squiggly bronchial vessels all the way around. I'm not sure why the patient had one. If they had some small event when in utero or what he developed all of these little fistulas. And then Vargas just linked his seminal paper on coronary pulmonary artery fistulas. I remember that he wrote that one a little while ago. So for whoever's interested, there's the link on the chat box. And I think there's a couple of examples. Not this one. This is a fresh case, but there's some examples that are very good in that paper. Dan, anything to add?
No, I would just say that usually those vessels are part of the ring of Vuissance, which is a communication of collaterals between the left and right coronary circulations anterior to the pulmonary artery.
Correct. Very good. Thank you. So yes, and again, for those trainees and whoever that want to know more, the arch of Vuissance usually is created by it's usually the conal artery, so the one from the right and the left, and they can complete that arch in front of the MPA, and that's part of the vestigial embryological arterial flow to the truncus arteriosus in utero, when everything is kind of one big vessel. All right, those were my cases. Who wants to go next? I know Diana, Carol, and Prachi have cases, so let's see. who do I have here? Carol, I think you're the first one. No, Prachi, you're next. I'm gonna make you presenter. I'm gonna go by order of in the chat box here. Let's see. So I'm making you presenter. You're gonna have to accept the invite. There you go. And we can see your screen. So your microphone doesn't seem to be working right now. Okay, got it. All right, so we'll try while you work on that one. We'll give control to Carol. All right, Carol.
Okay, we'll see if.
You're it. Well, your microphone is working. That's always good.
Yeah, my microphone is working. Now I'm just going to my privacy thing. I always seem to have these issues.
No.
Do I have control now?
I sent you the invite, so if you accepted it, you should have control.
I have to rejoin.
Okay. All right. Let's try Diana while you do that. All right,
Let's
Dr.
try.
Livanovich, you want to try?
Yes.
Let's see. You got the invite. Ready?
Okay, let me share. Okay, let me share and let me see if I can share what I want to share.
So we can see your
Now,
images.
you do see my images, and actually, I am glad that I can show you this because this is another example of Uson's artery circle we were just talking about.
Perfect.
Because we know that this, and this is exactly as Jacobo said, this is a colon branch that creates a Uson's, or essentially reopens the part of the circle, of the Uson circle, then goes all the way and makes a collateral with the LAD. And the reason it happens is because of this severe stenosis of the proximal LAD right distal to a patent stem. So we did do this patient as part of the workup of a recurrent chest pain, and that's what we found. And this is part of the Uson's artery. And I always have trouble to pronounce it, but I learned that we are not pronouncing the V, so it's Uson's artery. Or unless I'm wrong and we should pronounce the V, I'm always confused. But that's one of the cases that I wanted to show. And let me show another case. Let me switch to a different PowerPoint, and let me start with this image. And do you guys see my screen?
Yes.
Yeah.
Okay. So this is those are two patients with the same disease. Just selected images from the same from two patients. So this is the patient number 1, and what you see here is a large pseudoaneurysm coming out of his left subclavian artery. And then those 3 images belong to patient number 2, where you see a pseudoaneurysm originating from the thoracic aorta, descending aorta, another aneurysm of his LAD, and another one of his popliteal artery. So this is the same disease, 2 different patients. Now I'm going to show you patient number 3 with the same disease, where you can see large and small aneurysms of the pulmonary artery. You can see the pulmonary artery aneurysm originating from the segmental branch of the right lower lobe. And if we look at the mix of the pulmonary arterial tree, we can see multiple small aneurysmatic dilatations of the vessels. And now I'm going to show you patient number 4 with the same disease, okay, but you can see that subclavian vein is partially thrombosed with some recannulation, and we can see multiple collaterals that are created to overcome this difficulty. So any ideas what disease I'm showing you guys? And I see that Dan Vargas is right on the spot. Yes, indeed. That's what he wrote. Now, here comes the tricky part. So the true name of this disease is Behçet disease. That's how the entire Turkey medical community pronounces it. Somehow in the States, it's called Behçet. To the point that I had a case like that on my boards and I said Behçet and nobody understands what I'm talking about. So it's a Behçet disease, but the spelling is Behcet, and this is a disease which is known by involving pulmonary circulation, arterial circulation, and venous circulation at once. And also small, medium-sized, and large vessels can be affected. Really, the main population affected by that is in Turkey, but also could be seen throughout the Middle East. And this is just to show Dr. Behçet, who described that disease, which is the 3 symptoms syndrome: uveitis, after stomatitis, and genital ulcers. Do you guys see that in your practice? Or practices, I should say?
I've seen one.
Yeah, I can't recall it. I think I saw one during fellowship, but not since. It's definitely not come. I know a patient closely, but I don't recall seeing vascular manifestations.
So I haven't seen even one patient in the 15 years that I'm in Boston, and all my collection of patients is from Israel, where it's relatively common disease among both Jewish and Arabic population.
We had a great case here of Behçet disease recently. I can't remember where the patient was from though.
Usually those patients are from the Middle East descent. At least the overwhelming majority of them. This is what I wanted to show.
Those are. Thank you for sharing those, because those are great. Awesome. And I think so. Brad Chief has a new microphone that might work, and I know Carl joined, of course, to be able to present. So let's see, who's do I have? Let's see, Carol, why don't we try you first? I'm gonna make you presenter. You have to accept now.
Yeah, I'm not sure why I always have difficulty with my privacy. Can you share again? Or give me?
Of course not. Let me see. Okay, so I have to. I already shared, so let me do it again. I need to cancel that one, and then give it back to you.
I think you're making me again a presenter, Jacobo.
Yes, I am, to try, because that's the only way that I can undo Carol's invitation.
Okay.
Hopefully it won't direct me again to the same privacy.
Okay, here we go.
Oh, thank you. Okay.
All right, perfect. We see your screen. We're seeing somebody's screen. I hope it's yours.
Yeah, you're seeing there. Okay. Now do you see it? Yes. I
Yes,
think you
yes.
see it now?
Yeah, works
Okie
perfectly.
doke. Wonderful. Okay, so this is a 59-year-old man who presented to the ED with an inferior wall STEMI in December of last year. He had a coronary angiogram that revealed chronic occlusion of the LCX and a culprit lesion in the RCA, and an echo was performed, followed by an MR. This is a cine, and this case is from LC in Toronto. And so this is a short axis cine, and so you just concentrate on the lateral wall, the anterolateral and posterolateral wall of the LV. You can see there's an outpouching there, and there's thinning of the myocardium overlying this area. And so moving on to, this is a static image from that cine in the mid wall. So you can see the outpouching here. And then on the late gadolinium enhanced images, you can see enhancement. There's transmural enhancement in the mid and at the base of the LV. And you can see some areas of low intensity, which probably represent areas of microvascular obstruction. So this is consistent with an MI. And if you look at the pericardium, which is surrounding the heart, there is enhancement of the pericardium. Okay, so you have an aneurysm, so this area is not contracting, so it's pooching out as the ventricle contracts, and then you have transmural enhancement with areas of microvascular obstruction. So this is an aneurysm. And so my question to you, by assessing all of these factors that I've shown you, and especially the enhancement of the pericardium, which is away from the left ventricular aneurysm, my question is, what type of aneurysm is this? Is this a true aneurysm, a false aneurysm, or I'm not sure? Anyone want to venture a guess?
I think it's supposed to be a false aneurysm, but it sure looked like a true one morphologically.
Exactly. So that's great. Let's look at, you know, how you differentiate true and false aneurysms on MR. And MR is really very good at differentiating these two types of aneurysms. So true aneurysms are really much more common than false aneurysms. They contain some myocardial elements in their wall. They're more commonly anterior and apical. They contain thrombus less commonly than false aneurysms, and they have a lower risk of rupture. And usually they're managed medically unless there's recalcitrant heart failure or very bad arrhythmias. And false aneurysms, as I said, are much less common, and they're due to the rupture of the myocardium that is contained by pericardial adhesions. And so the wall of the aneurysm is formed by organized hematoma and pericardium. They're usually inferior or posterior. Thrombus is more common in them, and they have a higher risk of rupture irrespective of their age. And so in general, these are surgically repaired. So going back to our case here, we have an example. Sorry, this is not our case. This is an example of a true aneurysm, and this is a short axis still image from a cine. And you can see this outpouching. It's thin walled. On the perfusion imaging, you can see there's decreased perfusion of that area in keeping with something vascular in nature. And then post on the late GAD imaging, you can see transmural enhancement, and this is probably a bit of thrombus and also some microvascular obstruction. So this is a true aneurysm. There is no enhancement of the pericardium away from the sac. So the characteristic of a true aneurysm is it has a wide neck. So the ratio of the maximum diameter of the neck of the aneurysm, let me just get my pointer, to the internal diameter of the cavity is usually around 0.9 to 1. So you can see here the aneurysm, inside the aneurysm is almost the same width as the mouth. And then there's this new paper published by Pamela Woodard in JTI, just I think it was March or January, sorry. There is a drop-off of the thickness of the myocardium. Usually it's less than 50% of the myocardial thickness 1 centimeter away from the neck of the aneurysm. So here it's a gradual tapering, and it drops off less than 1 centimeter away from the neck of the aneurysm. And finally, as I said a couple of minutes ago, there's no pericardial enhancement away from the aneurysm sac. So if you look at that pericardium, it's not enhancing at all. Whereas a false aneurysm, which is shown here, there is again an outpouching in the inferior wall. So this is a good location for a false aneurysm. There is, on the perfusion run, decreased perfusion in the inferior wall in keeping with a vascular abnormality. And then there's transmural enhancement and probably difficult to differentiate a small thrombus here from microvascular obstruction because the blood is also lighting up significantly. So it's hard to tell if there's a very, very small part of enhancing myocardium lining the cavity of the left ventricle. And if you look here at the neck of the aneurysm, the ratio of the diameter of the neck to the internal diameter of the cavity is 0.25 to 5, and that's very sensitive for a false aneurysm. In addition, there's more than a 50% decrease in the myocardial thickness 1 centimeter away from the neck, and that's said to be 91% sensitive and 97% specific for the presence of a false aneurysm. And if you look at the pericardium away from the aneurysmal sac, there is enhancement here of the entire pericardium surrounding the heart. So that's a sign of a false aneurysm. So just going back to our case, with an aneurysm in the lateral wall of the left ventricle, it has kind of a confusing presentation because it has a wide neck. It has, approximately 50% thinning of the myocardium, so it's sitting on the fence. And it has pericardial enhancement away from the aneurysmal sac. So it's presenting both features of true and false aneurysms. And at pathology, however, it was indeed a false or pseudoaneurysm. So this is just an example of a case that that presents features of both types of aneurysms, just to point out that sometimes, MRI is not 100% specific for differentiating the two types of aneurysms. So although it is extremely good at it, it's not 100% specific. So always remember that. I have a companion case showing of a 55-year-old who presented to the emergency department with an acute anterior wall MI. A coronary angiogram was done and a stent was deployed in the LAD, and she returned to hospital 6 weeks later with dyspnea and fatigue. And this is her chest x-ray, and it's a little bit similar to the one that Jacobo showed, but in this case, this is going to be due to an aneurysm that she presented with 6 weeks post-MI. And she had a very, very large aneurysm in the anterior wall and apex. And it has a very wide mouth, so it does look like a true aneurysm, and it's in a location that is more common to be a true aneurysm. It has more than 50% thinning of the wall, 1 centimeter away from the aneurysm neck, and it has pericardial enhancement that is away from the aneurysmal sac. So another one with somewhat confusing picture, and at surgery this was a true aneurysm with fibrovascular epicardial adhesion. So in this patient, she probably had Dressler syndrome, which is a pericarditis that patients can develop post MI or post intervention. And she had diffuse pericardial enhancement because of that, even though at surgical pathology, this was a true aneurysm. So just some take-home points here. Signs of true and false aneurysms have been described. I must emphasize that, you know, all the literature that I reviewed were from very, very small series. So we do base what we know on very, very small series. Indeed, at postmortem, true and false aneurysms are found equally at postmortem. And so it's only antemortem that we see false aneurysms as being much less common than true aneurysms. It can be difficult to differentiate the pericardium from very thin enhancing myocardium and blood pool that's over the aneurysm, overlying the aneurysm. And pericardial enhancement away from the sac can rarely occur. I would say probably more likely in the setting of Dressler syndrome. But MRI still remains the best imaging tool to differentiate true from false aneurysms, but it's not 100% specific. So that's my cases. Any questions?
No, really great cases. Any questions, guys? Any comments?
Terrific case.
Really, really nice
And
cases.
the other cases, excellent cases.
Okay, do we have time for Prachi? Yes.
We should have. I just made her presenter.
Yep.
See, Prachi, if you can accept. It was working last time when we tried it.
Okay, I'm going to try out. Can you guys hear me?
We can hear you and we can see your
Yes.
screen. Thank you so much for joining.
Okay, so I wanted to show you, this is a chest CT that I had read recently. This was a woman who came in with a history of head and neck cancer. And let's see if I can play the axial images. What I want you to do is look at the left subclavian artery particularly. So here is the left subclavian artery, and then you don't see any enhancement. I can play it one more time. So here again, you see the left subclavian artery, and soon after there is no enhancement at all. So here is one of the images. This is the origin of the subclavian artery, and this is kind of where we lost the enhancement. Now this patient also got a CT neck the very same day. It was done in the same setting. Here is the CT neck images. And here is what the left subclavian artery looks like. So you can see the left subclavian artery here. And wanted to see what your thoughts are before I show you the next set of images. So chest CT, neck CT done same day. Chest CT shows this appearance, whereas a neck CT showed a patent appearance. And just to keep it moving, I can show you the scout images and see if you have any ideas. So I'll give you guys another couple minutes, and since we're kind of getting to close to the end of the hour, any ideas from anyone?
Is that a
So-
cervical rib on the left?
Okay. But how does that explain what the discrepancy we see in the chest and neck?
Arms up, arms down.
Exactly. So if you look at the scout image, this is the scout image for the CT neck, have the arms in adduction, whereas this was the scout image for the CT chest with the arms in abduction. So even though we did the scan for totally unrelated reasons, this was actually an interesting case because you could diagnose thoracic outlet syndrome in this patient. Clearly with the arms in abduction, you see a complete or severe narrowing of the left subclavian artery. So just wanted to share this with everyone.
It's a very cute case.
Yeah, really cool.
Thank you.
Yes, that's pretty great. Any questions or comments, guys? All right, we're just a couple of minutes before 5. Anybody else has a quick show and tell that they want to share, or wait for the next one? All right. Well, with that, thank you for a great meeting. Thank you for some great cases, teaching, questions. Really nice to meet some of the new names on the chat box and all the new trainees and future radiology trainees. Congratulations and good luck on everything. We hope to see everybody here next month. Remember, it's the first Tuesday of the month at 4 p.m. Eastern time. So looking forward to continue seeing you guys and showing some great cases. Thank you all.
Thank you, Jacobo, for organizing it every month and making it bigger. And every time we attracting new people. So thank you very much.
No, it's a pleasure. Thank you guys. Take care.
Bye.
Thank
Thank
you.
you.
Bye.